Good afternoon, and welcome to an Ars Technica live event. I'm Beth Mole, Senior Health Reporter for Ars Technica, and today we're talking about the crisis at the CDC, what we're losing and what it means for our health. For our discussion, we have three experts here who probably have more insight into this topic than anyone else. Three former top leaders of the CDC, each having decades of experience as esteemed public health experts, and obviously they have extensive knowledge of the agency. We're honored and grateful to welcome them. We have Dr. Debra Houry, who is the Chief Medical Officer and Deputy Director for Program and Science at the CDC. In her role, she oversaw 9 centers and the Office of Science, collectively controlling a budget of over $6 billion. Before her departure, she was the most senior leader for the agency after the CDC Director. We also have Dr. Daniel Jernigan, who was the Director of the National Center for Emerging and Zoonotic Infectious Diseases. His career at the CDC spanned over 30 years, in which he led responses to dozens of health crises, including Ebola outbreaks and the 2003 SARS pandemic. He's also a national leader in responding to influenza threats. And we have Dr. Demetre Daskalakis, who is the director of the CDC's National Center for Immunization and Respiratory Diseases. He managed national responses to Mpox, measles, seasonal flu, bird flu, COVID-19, and RSV outbreaks, among many other things. He also previously served as the director of the CDC's Division of HIV Prevention. So welcome, and thank you so much for being here. Before we get started into our discussion, I just want to give a quick note to the audience that we have a question and answer session at the end. So if you have any questions, please feel free to drop them in the YouTube comments. So as we get going, I mentioned, of course, that you're all former leaders at the CDC, and that's because on August 27th, upon the firing of CDC Director Dr. Susan Maneras, just weeks after her Senate confirmation, all three of you submitted your resignation letters together in coordination. But of course, that decision followed not just the dramatic ouster of Dr. Maneras, but months of upheaval and turmoil at the agency. To set the stage a little bit for the audience, just to give them a few things that have happened, the CDC has since January had several rounds of extensive cuts and layoffs, going from a staff of around 13,500 to fewer than 10,000, as well as deep funding cuts. Numerous aspects of the agency's work have been cut back and weakened, if not entirely shut down. On May 27th, Health Secretary Robert F. Kennedy Jr., who's an anti-vaccine activist, announced unilateral changes to the COVID-19 vaccine recommendations via a video on social media, which blindsided CDC staff, which we can talk about that. On June 9th, Kennedy fired all 17 members of a vaccine advisory panel for the agency, the Advisory Committee on Immunization Practices, or ACIP. He then replaced those experts with hand-selected members, many of whom have expressed anti-vaccine views and criticisms of COVID-19 pandemic responses, which are all in line with Kennedy's ideology. Since then, the ACIP has made several major changes to federal vaccine recommendations, all of which have been strongly rebuked by the public health and medical communities. On August 8th, a gunman fired over 500 rounds into CDC's campus in Atlanta, Georgia, leaving bullet holes in your offices and tragically killing local police officer David Rose. The gunman was reportedly motivated by vaccine misinformation. Kennedy responded to the shooting on social media the next day, about 30 minutes after posting pictures of a fishing trip. After Dr. Maneras' ouster, she testified to the Senate on September 17th that she was fired because she refused to basically rubber stamp vaccine changes made by Kennedy's ACIP members. Dr. Houry, you testified at that hearing alongside her. and told senators that resigning from the CDC was, quote, one of the hardest decisions in my life, end quote. So to kick off our discussion, I want to go back to that day, that decision, and what it meant for all of you. Dr. Houry, maybe we can start with you. If you could say a few words about how and why you made that difficult choice. Were there specific events that strongly influenced that decision?
Yeah, there were quite a few events that led up to it. This was not an overnight decision for any of us. I was probably the first of the three to be ready to walk out the door, I think because I was in the office of the director and really seeing a lot of it before the rest of us did. The staff cuts in March initially would have been even worse, and that was when I first thought I was going to leave when they had planned to wipe out all the non-communicable centers completely. I couldn't be part of that. I was going to leave and was able to negotiate with Doge and change some of the outcomes. I'd say April was tough when we started dealing with the measles outbreak, and Demetre and I had to, send corrections to the secretary's office on like that there's not fetal parts in vaccines, or correcting other things. And then Dan and I got to have time together when it came to, David Geyer and vaccine safety data. Um, when the vaccine committee members were all fired, I actually called Susan and told her I didn't think I could wait until she was confirmed that I was concerned about integrity for the agency. She asked me to stay, said that she was coming soon and would enforce scientific rigor and transparency. And so that really, I think, gave all of us on this leadership team here hope that there would be some changes. After Susan arrived, she was unable to make simple changes, including like changing the designated federal official. I knew then I would be done, and I did not plan to stay until the September vaccine committee meeting because um, my reputation, my integrity, you can't get that back. And so I had already planned to leave at that point. The shooting then happened, which, devastated our agency because it was a violent attack fueled by misinformation, of which the secretary promotes misinformation when it comes to vaccines. And so it was very personal for many of the staff, and many are still traumatized. But the three of us stayed through that. When Dr. Menarez received a memo that she was not going to be able to make staffing or policy decisions, we knew we didn't even have an effective director at that point. She was then called in to meet with the secretary, and I called Dan and Demetre to let them know this was our time. The three of us had already met previously in the months before over what lines would we not cross. And that Monday, we actually voted on would we get fired, would we quit, we were going to do it together, and we wanted to walk out together and use our voices together. So they submitted draft resignation letters to me. I kept them in my inbox, and the day that Susan was escorted out, I hit send.
Wow. Dr. Jernigan, do you want to go ahead? Oh, I think you might be on mute.
Sorry. Yeah, so Deb had mentioned a couple of things there that were really important for my decision making. The main thing was on just what we were being asked to do, what kinds of information, what kind of data that we were asked to provide to people outside of the agency, outside of CDC, to do analyses and find things that we really didn't understand what it was that they were looking for. So for us, there is a thing called the Vaccine Safety Data Link, which is a collection of information about how the safety of vaccines and how you can monitor the safety of vaccines in a large population. Historically, that's information that's done methodically. You have a whole group of people to look at that data. We were being asked to hand over a significant amount of information to people that we didn't know who they were, did not know what the scientific questions they were asking, weren't sure what the scientific process and the protocol was. And so that raised a number of red flags for us. My center has had 1,600 people in it in various different kinds of emerging infectious diseases, but it also had the Immunization Safety Office, and that's why I got thrown into this very quickly. So this raised questions for us, and we started to go through a process, frankly, based on the way that we handled issues over the time in past outbreaks. We would ask sort of what are the legal issues, what are the scientific issues, and what are the ethical responsibility issues. And so for us, we had to have the Office of General Counsel write down why what they were asking us was legal, because they were asking us to do things like not use data use agreements, not have assurances of confidentiality, waive things on IRB. Those are things that we think are really important. And from a legal standpoint, they said, yes, we can do this. From a scientific soundness standpoint, we did not know what kind of studies they were going to do, what their study questions were. And so from our standpoint, we could not gauge exactly what it was scientifically they were planning to do. And then finally, from a scientific and ethical responsibility standpoint, we saw that they were asking to use data without any of those assurances of confidentiality, the data use agreements, the IRB, et cetera. Those things were the kinds of things that are required in my center. If you're going to be doing science, you're going to be doing studies, you need to be doing those things. So for us, that really, in our center, that kept pushing us closer and closer to that line. I think, as Deb mentioned with the shooting, that shooting occurred. We were in the building when that happened. It was a very devastating thing, especially for the staff to suddenly be confronted with the fact that it's less safe in Atlanta on campus than it is in the field in West Africa or in the laboratory where you're doing a very high containment type of lethal virus work. So that was very hard for the staff. But then to find out that the motivation for that shooting, where Deb has said in the past, each one of those bullets essentially had somebody's name on it. That person was trying to do harm. And so for them to see that that was motivated by anti-vaccine or anti-CDC rhetoric, that really put us in a space that we weren't ready for. So that pushed us that much farther to the line. And then when Susan Menars did get fired because she wouldn't fire us and she would not lower her integrity, that was enough. And as Deb mentioned, we got together, had it all sort of worked out, and then walked out to a large crowd of people that were extremely supportive and quite helpful for us, because you don't know if you're doing the right thing at that time. Feels like it, but to have all of those folks supporting you was very important for us.
Thank you. And Dr. Daskalakis.
So everything that Dan and Deb said, plus I think one of our sort of early warning signs that began, the feeling that it was not going to be tenable to stay at CDC without doing harm, was that we never met with the secretary. So in the months and months that we were there, despite the fact that I was in charge of the, most of the vaccine program at CDC, I never had the opportunity to brief the secretary, despite offering briefings on several occasions to a senior leadership team. But it was clear that he was getting information from somewhere, but it wasn't from CDC or other scientists that, I think had a track record and access to the data that he would need to be able to sort of make such definitive statements around vaccine. So I think, to summarize, for me, it was clear that the mission was to make CDC a wolf in sheep's clothing. And so, the clear effort was to sidetrack scientists. That happened in the advisory committee for immunization practices. It happened with the announcement of the changes to the COVID-19 vaccine schedule. It happened with the dismissal of the ACIP members. So it was sidelining the scientists and really hijacking the agency. And having ideology replace science, but under the rubric and the platform of CDC that gives it validity. And so for me, when I was working in the vaccine space around the advisory committee for immunization practices, when it became clear that the scientists were going to be sidelined, they were not any longer going to be able to chip in to the vision of what the agenda should be. They were not able to recommend members of work groups, which is really where 90% of the work happens. The meeting is just like the fin of the dolphin hitting the surface that you see publicly, but so much work happens underwater there. And they weren't allowed to put anyone on. And so the folks, the new ACIP members, just put on ideology clones onto the work groups so that the data that they heard and the data that were presented were not data that in any way had been vetted nor had gone through any process. And that, I think, is really important. Like, routinely, the CDC goes through process. And one of the things that they said was that the new ACIP members were there to avoid CDC bias. And I'll tell you, the only bias that CDC has is to make sure that only the best science is considered for recommendations so important to American children and Americans. So when Dr. Menares was being dismissed, we had a glimmer of hope before then that she was going to be able to negotiate a path forward where CDC scientists would actually have a role at the table or a place at the table. When we saw that, it was clear that all we had was a wolf in sheep's clothing, and that's actually played out in the last months after we left. So that's why I resigned. Couldn't do that. First, do no harm.
And I think I'd say for all three of us, we don't regret it. I mean, it was a tough
Not at all.
decision. It took us, a while to get to that point, but it was the right thing.
Yeah, no regrets. Agree.
So I think one thing that's really striking with what Dr. Jernigan and Dr. Daskalakis you just mentioned about you didn't ever talk with Kennedy, and there was you had no clear understanding of like some of the work they were trying to do with CDC data. But they obviously were doing something, and I think you've mentioned this in the past. They were communicating in a way. How did they get things done with CDC scientists? Any of you can jump in there.
I can start. I mean, from my experience on the vaccine safety side of things, most of the engagement that I had that would give the direction from the secretary was coming through intermediaries.
Okay.
So there were people that were counselors at the HHS level. There were people in the immediate office of the director at CDC that were essentially all their role was basically to pass through that kind of information. So that's how I understood what we were being requested to do. What I didn't recognize is that the secretary was actually having conversations with staff at CDC that were in other parts of the agency, but who the secretary had past engagements with in the past. So, I mean, the secretary, when asked at his hearing, who are you getting your information from? He mentioned one of those people, not any of the folks that are on the phone here. So I think that's an indication that something was not right, and the means by which we were being engaged just was so different than what we had had in the past.
Right. And just to give a little context, so the past CDC directors, Dr. Walensky, Dr. Cohen, how often would you normally interact with them? Was that a common occurrence? Okay.
I mean, extremely routine. I mean, we even, there's some things at my center. I mean, so my former center runs the respiratory virus season. And so that happens every year. And so we even had very routine meetings, not even sort of in the setting of an outbreak beyond the sort of normal seasonal outbreaks. And those ran every the entire year, sometimes once a week, sometimes every other week, depending on where activity was. But we never had an issue with access to leadership at CDC, nor any sort of issues with access to leadership at the secretary's office, depending on what the circumstance was. Like I had briefed the secretary before Secretary Kennedy on bird flu, on measles, like on so many topics. So it just seemed very odd that we didn't have that access.
And this was not political, because under the Trump 1 administration, we regularly met with the secretaries. I still talk with former Secretary Price. I mean, it was really a collegial relationship, and those secretaries had really good advisors around them as well, very, clinical, scientific experts.
Got it. So I kind of want to hit into the sort of main thing I want to hear from you guys and drill down. We've heard a lot since you guys have left. You've been working a lot to raise the alarm about what's happening at the CDC, and sort of heard these big picture things. So I want to kind of drill down into really some of the things we're losing in the agency. And so you guys just last month wrote a nice article, a commentary in The Lancet on November 26th, titled U.S. CDC, a public health agency in critical condition. And in that, you lay out the sweeping changes that have happened. And so I want to get into some of those, but I wanted to start also with what we're losing at the CDC by losing all three of you as top leaders with extensive knowledge of the institution. So if of all the things that have been cut, of all the changes that have been made, I'm just curious, from if you could go back to the agency and help work to restore it, what would be your top priorities in your former roles with the ability, with the authorities you had? What would be the first fire you would put out? What teams or projects would you be urgently trying to rebuild? And we can start with Dr. Jernigan, I guess, just to give Dr. Houry since he was first last time.
Yeah, so I think there's a couple of things. There's a mix of issues that are playing in here, or drivers. There are things that have to do with potential budget cuts or actual budgets that have been cut because of the loss of supplemental funding. There are staffing cuts that occurred because of the DOGE issues. And then there are changes to the agency because of proposed Administration for Healthy America, or AHA, a new entity that has not been approved yet. If that were to happen, that would also further mess up the CDC. And then in addition, there are retirements, RIFs, all these other things where people have decided that I just can't take it anymore, even from intimidation, people leaving. So one thing I think is just in staffing, what have we lost there? I think there's a phenomena that's happened. You mentioned sort of the upper part of the agency. If you go to the CDC leadership site, you'll see all the political appointees that are on there, but you can also see the other center directors, and almost all of them are acting directors. And 3 of them, the ones that we were in, don't even list an acting director any longer. They just say vacant. And so it's a sense that it's okay to get by without having that high leadership in place. And so what does that mean from a practical standpoint? My concern is if we were to have a major issue right now, you would end up a big health threat, an infectious disease threat, another radiologic threat, whatever. We would be caught off guard. To me, without having that leadership in place, you're essentially an army without commanders. So it's a bad situation there. One other one I just want to mention that we did point out in the Lancet article was just on the global front. And right now, if you look at the budgets and what are being proposed, they just cut completely a lot of the global programs. That's on top of losing USAID completely. And while there may even still be the funding that's there at the State Department, it's not exactly clear or how that's going to be implemented. And so what's happened? What have we lost? We've lost all the resident advisors that take care of malaria in the field in Africa. We had to pull them back because there wasn't funding for them. They didn't have the authority to be there any longer. That means that there are kids that are going to get malaria. There are people that aren't getting the appropriate therapy and are going to die. And so that just means that once that increase is there in Africa, anytime there's a traveler, there's just a greater risk that we can get malaria in the United States. A couple of years ago, we had a number of cases that were actually being transmitted in the United States because of that. So we don't want that to happen. We want to detect things first overseas before they come here. But in this current setting, it does not look good for the global side of things.
Gotcha. Dr. Houry or Dr. Daskalakis, would you like to jump in, either one?
Go ahead, Demetre.
Great. So I think, one of the things that I would try to express loudly if I were still or had the ability to make a change is that, CDC really functions as like an interconnected organism, and none of the outbreaks, none of the sort of emergencies that we have live in isolation within one center or another. And so I think that there's so many examples of that. So I think, Dan and I worked together with another infectious disease center during the Mpox outbreak that required activation of not only the vaccine side of the fence, but also the experts in pox viruses, as well as the experts in sexually transmitted infections, et cetera. When we activated a response to H5N1, true story, we had people from NIOSH on the ground in Texas trying to figure out how to deal with air handling systems in hospitals because we had newborns exposed to measles because of the way the air handling system works. Those people were riffed while they were on the ground in Texas, trying to contain a measles outbreak and trying to prevent infections in newborns. They switched that plan and brought them back for a while. But ultimately, that I think is the point that oh, and Zika, which I think we can speak about in detail, like that isn't just something that Dan's center does. That's something that required like maternal fetal health to be a part of the story. And so, as there are sort of strategies to move parts of CDC to AHA, not with a clear plan. I think that the one thing I would wish on my dream list is to say, can we change CDC using a strategy rather than using randomness and ideology to really carve out the things that they want to see disappear? I mean, I think thinking about the HIV space, that center, that division is not able to do its work because it doesn't know what its future is minute to minute. And that's going to manifest itself in increasing HIV infections and less resources and skill to be able to address outbreaks on the ground. I think, the people that do the really excellent HIV communications are actually on administrative leave. And so that's happening while San Francisco and New York City have increases in their HIV based on their new epi data. And so I think what we're seeing is if you disable parts of CDC, that means that everything is not as robust. And the effect is that you're not able to deliver on the mission to protect the health of people.
Right. So I kind of want to go back to that point you made about the interconnectedness. But Dr. Houry, I want to give you a chance to answer before we
Yeah, so the only thing I would add, to what Dan and Demetre said, because I think staffing is really a key thing as well as the programs that are being lost. But I think it comes down to CDC was an apolitical, scientifically driven agency. And I say was. When you look at the website right now, there's information on abortion, homelessness, immigration. That doesn't belong on the CDC website. It should be apolitical and neutral. We are seeing political interference, which is eroding scientific integrity. And that started early. Like when they had paused the MMWR, we did get it back. But I think that was a signal that early on there was going to be more political interference. Looking at the measles toolkit, they'd wanted to include medications that weren't evidence-based, and that can result in harm to people. That's concerning. These aren't just wording or ideology changes. These are things that can hurt people, and that's what we couldn't do. And so I think looking forward, as long as there continues to be political interference that is eroding scientific integrity, CDC is not going to be able to do its mission, and a large part of that is being driven by the secretary. I hope President Trump steps in and protects his legacy. Under his first administration, CDC thrived and did well. This is being driven by the secretary.
Gotcha. So I just want to just go back just a little bit. So you mentioned the MMWR, that's the Morbidity and Mortality Weekly Report. That's a publication that the CDC produces, has critical data and analysis on outbreaks and other things, just for the audience. And then RIFT, just to make sure everyone understood what that meant, was reductions in force. That's basically layoffs. So I think I want to go back to, I think what Dr. Daskalakis was mentioning. I think so. In your Lancet article, I wanted to ask you. There's a sentence here that you mentioned. Perhaps, quote, perhaps most damaging is the collapse of the CDC's administrative and program support structures that connect and nourish all the core functions of the agency, allowing science to flourish and work to be implemented. So, is that something in terms of how the? So, tell me more about that. And I don't know if Dr. Daskalakis, do you want to join in or jump in, or Dr. Houry or Jernigan, whoever?
I defer to Deb first, and we can chime in.
Okay.
So I would say, when you're looking at like a scientific enterprise, and you don't have an ethics committee or an ethics office, you don't have the institutional review board, and you don't have the unit that oversees all the federal advisory committees, I really don't see how you can have gold standard science or radical transparency. And those are priorities of the secretary, but they were targeted, for termination. Similarly, when you do things like take out the entire human resources office, it's unclear to me how the agency can function. So a lot of these changes that are being specific to the CDC, you really can't function if you don't have the core ability to do things.
Got it. And does anybody?
Yeah, just to chime in on the the human resources component, we talked about the loss of the staff at the top. But perhaps one of the longest lasting problems that CDC is going to have is that the pipeline in is actually really at risk. They took away the ability to have these Title 42 fellowship type things, these term employees, the use of the Oak Ridge Fellowship Program, all of those things, those fellows program that bring in that young scientific talent, those have been stopped. And so you've cut it off at the head, you cut it off at the tail, and just to support who's there still, there are a lot of very smart, very dedicated people. People have, think about where they want to work, and those that are at CDC, that's the only place they wanted to be, because it's the incredible work that you can do there is just amazing. But right now, it's very difficult to do it. You don't have the ability to get the money out because the contracting staff and the grant staff are not there. You can't hire people because the HR group is not there. You can't get the science done because those that have to approve scientific protocols aren't there. And even if you're from outside and you want to know what's going on at CDC, the Freedom of Information Act office is also gone. So it's death by 1,000 cuts. You just get rid of all these little things and the overall program is just idle. There's inertia because of all of those different cuts that have occurred.
And I'll just echo that and say, in general, like, we found ourselves having to go to Deb to sort of flag things that were critical, that weren't moving through the administrative channels, even though that wasn't necessarily her role. And I mean, I think that in the absence of having a Dr. Houry there, I don't know how folks who are on the inside can sort of get the adequate attention to make sure that either money moves or contracts get done in a way that allows work to continue happening, given so many cuts to the core administrative functions of CDC. So I think that there's also the element that, when you look at that list of people in the office of the director, there's not one single scientist who has experience in federal public health who will be able to execute on what's needed. And so a lot of what happens when you try to, jump up and down and flag a problem is they don't understand. And that is, I think, really hard for the staff there who are still trying to deliver on mission.
Got it. So what are your fears or concerns about how some of these changes at CDC will become apparent to the public? There's a lot of big changes, huge staffing cuts to the National Center for Chronic Disease Prevention, CDC injury prevention programs, CDC's environmental occupational health. I think one thing that really stood out to me is the workforce for radiation emergencies is below requirements. You guys mentioned this in the article. And quote, requests from states for toxic and chemical exposure assessments are likely to go unanswered. So things like that, as a member of the public, sound very alarming. What sort of things do you feel people should be worried about, or should at least know about, and sort of things that maybe would go on behind the scenes and they might not know what CDC is up to, but once it's gone, they might notice. Dr. Daskalakis, do you want to jump in?
Sure. I think my first concern is, and I'm going to up the ante from what Deb said, that CDC has become a vehicle for disinformation, not just misinformation. And so disinformation, I think, is for a goal, and that goal is to destabilize the vaccine program in the United States, and then ultimately to create opportunities for folks in wellness industry, as well as individuals who are litigators, to be able to take advantage of a severely damaged system. And so I think what I'm concerned about is what I was concerned about the day that I quit, that we now have a wolf in sheep's clothing, and that wolf in sheep's clothing will continue to create documents that are source documents for lawyers and for others to be able to move forward policies and litigation that will potentially damage the ability of the U.S. to protect itself from completely preventable diseases. One of the things that I'm really worried about is that this is not going to manifest itself in the next 3 years. This is going to manifest itself beyond that. as vaccine confidence is further eroded, as vaccine rates continue to decline. I think that we're going to potentially be in another administration when we start to see the outbreaks, and that's going to sort of create a scenario of blaming a new administration and potentially also blaming CDC that has been in effect crippled from being able to deliver on its mission. So CDC will continue to be a very easy scapegoat, especially as we see these events moving forward for various reasons. But I think ultimately, I think I'm really scared that we're only seeing the beginning of things like putting up a vaccine and autism website with no good data, to the point that people who were cited in the website said they have misconstrued my reference. I think the National Academy of Medicine, right, said so, and the Institute of Medicine said so, and so I feel like there's more to come. But when you hear the words to the public, gold standard science and radical transparency, that is just jargon that is hiding the fact that there is no science underlying the work, and the only transparency is the transparent conflicts of interest that are being displayed by the people who are trying to manipulate communication coming out of CDC.
Right. Dr. Jernigan or Dr. Houry?
Yeah, sure. Just, I think a couple of things in the infectious disease space. I mean, people probably don't recognize, but there was not a flu campaign this year. And so, you sort of see these ads come through all the time. You're watching the Super Bowl, you're watching whatever, football, and there's, get your flu vaccine, or there's somebody that's doing it for you. That just was taken away. And so we don't know what the full impact of that is, but there's probably a nursing home patient somewhere that had to be hospitalized because of that. There's probably some kids that didn't get their vaccine and had trouble with it. So there are those kinds of things that have downstream effects that are being implemented. Another one is an emerging infectious disease. It's called Oropush, which is a type of virus that's actually transmitted through midges or with no-see-ums. And you go outside, you get bit, whatever. However, if you're pregnant and you get bit with one of these insects that has that virus in it, and we saw this a ton in the Caribbean last year, is you can end up with having Zika-like problems. Your kid can be malformed. You can have fetal demise. So those are things that you want to have the capabilities at the agency to really respond to. If we were to have a problem emerge like that right now, the birth defects people aren't there. We don't have the people that we can rely on to help with communication messages, because we also don't have the communicators, and for getting those policies together that help us to make sure that we can prevent those kinds of things from happening. I'm just concerned that things will be slower, they'll have less expertise, and the American public will not be getting what they need as quickly as possible, and then the overall harm can happen then.
What I would just add is I think the American public might think there's the expertise, because like at the vaccine committee meeting, we saw people that were labeled as CDC, but one was a political hire and one was a contractor. They had actually published a retracted paper. So, those are not, in my mind, CDC scientists. And so even the 16 plus politicals, normally there's 2 to 3. They're labeled as CDC, and some probably have been brought on as a career path. So I think people will hear CDC, believe what is coming from CDC, but it's not the traditional science-based CDC. So because of that, like Demetre said about the vaccine and autism website, when CDC puts something up like that, who do you believe? So I think the American public is not going to be able to discern these things.
So I definitely want to talk more about ACIP meeting. But just really quickly, I wanted to jump back to Dr. Jernigan about outbreak responses. And we're coming into the flu, so you mentioned the flu season. We're ramping up now. We're also still seeing H5N1 bird flu, and just that's in a sort of unprecedented outbreak. There was another dairy herd outbreak in Wisconsin detected. Are we prepared to monitor that? It feels like there used to be regular updates in that, and it's just kind of gotten quiet.
Yeah, I think overall communications across the board are less. I think there's a very slow quagmire that one has to get through in order to put a health alert notice out, in order to do a press briefing on something. I think the barriers to getting rapid communication are much worse than they have been in the past. And Demetre, who was over that center where I used to work, can also comment on the H5 work as well.
Yeah, I mean, I think that the data are flowing, and so that I think is really important. And so but what's different is that the communications around the data are anemic. And so, on FluView, which is like the data that's still going on FluView is great. Like, and that's that, I review it every week. It comes out on Thursday. It talks about what's happening both in seasonal as well as any of the variant flus, including H5. And the problem is that there was a case of H5 with mortality, and we didn't really hear anything from CDC, and that's not what we're used to. Like, I remember being on press conferences every week for a while around bird flu to make sure that people had the most up-to-date information, to the point that maybe they got a little tired of it when we didn't have a lot of new things to say. But I feel like that is the sort of finding that there's a recombinant mpox virus that was identified in the UK. I don't think that I've seen a lot of anything coming out of CDC in terms of a risk assessment. And so, I think that these are the things that that are concerning from the perspective of being prepared for a response. You want to give people information as things are evolving, not when we have human to human transmission of H5N1 and all of a sudden need to move really quickly in a way that we may not be able to, since $500 million in pandemic preparedness funding has been erased for vaccines. So that I think is my concern from the perspective of preparedness, is that, like, they're just not able to speak, even though the data is flowing and people need a hand. I think that this sort of secretary's statement, do your own research, is really nice, but that's really hard. And so that now transfers to the local health departments and some of the regional organizations that now have to sort of differentiate signal from noise for people, and they may not all have the depth and the expertise necessary to do so.
Right. Dr. Houry, did you want to add anything, or?
Nope.
Okay. So I wanted to move on to the ACIP really quick, but I just wanted to give another update or another reminder in case any of our audience members joined late. You can submit questions. We'll have a few questions at the end in the YouTube comments. You can put them there. So getting to this ACIP meeting, we've talked about the vaccine advisory panel a little bit. They met December 4th and 5th, and there was a lot of headlines from the hepatitis B vaccine decision that they made. So they dropped the universal recommendation for a birth dose of the hepatitis B vaccine. After that, 67 medical groups came out with a statement, basically, quote, this will, quote, will harm children. Even some members of the current panel agreed with that, notably Cody Meisner, who is maybe arguably the most experienced ACIP member. You're all shaking your heads, so that's good. He's a pediatrician. He's been on ACIP before. He said this will do harm. So just really quickly, what is your take on the current panel in terms of that decision, and then just generally, I guess. Dr. Houry, do you want to start since?
I think, what I would say with their decision is it's unclear why hepatitis B was even revisited. There was no new science. There were no new safety signals. And normally when we're not in the upside down world, normally when there's a vaccine that is going to be discussed, it takes about a year. And you have a specific work group with the experts evaluating new information, presenting the data way in advance to the public versus like posting the slides the day of and or not posting them or including anecdotes. So there was no reason they should have had this discussion to begin with. And then when you actually did look at the data, there are harms, as Cody Meisner pointed out, with moving even out to 2 months. And so it was not scientifically driven. They didn't follow the usual processes which are required by the Administrative Process Act, which is a procedural thing for the government. So my concern is no science, no process, really unclear how they arrived at what they did. And what's concerning is what does that mean for what happens in the future? You can just do something like that.
Right. So, and I wanted to just really quickly, so the things that, some of the methodology that's used generally, I think is called grading of recommendation, assessment, development, and evaluation, the grade approach, and then evidence to recommendations framework. So these are the sort of the methods. So when people talk about they're not using evidence-based methods to go about assessing these recommendations, can you just say a little bit about those processes and why they're so important?
I'll let one of my smarter colleagues do.
Demetre, why don't you do that?
I can start. So, studies can be published in lots of places. I'll start with that sentence. And they're of variable quality and should be weighted differently depending on what the recommendations that are being developed are. And so, the grade process asks questions of the studies. Are there biases? Is this a high quality study? Like really going through the studies methodically to say, this is something that should be given great weight or not given great weight when considering recommendations. So when you don't do that and you weight things based on your personal beliefs, which is what we've seen, what happens is that studies that have like poor data or are not a good study, or have bias, are all of a sudden raised to the same level as studies that in fact are well-designed studies with good data. So there's a lot of ways to do it. It doesn't have to be grade. Grade is just the thing that's used. But if you just throw all of the ingredients in the salad and toss it, that doesn't mean that you have a delicious salad, right? It doesn't work that way. And so that's what they did. They're just here, let's put everything in there. And then verbally, they denigrate the data systems that support some of the data that actually is of a higher quality. And I think that was something that you see consistently with this group saying, well, that system doesn't cover every American child because we don't have universal health care. And so that is one of the strategies. Then after all of the things are graded, the next part is the evidence to recommendations framework. And this is a really, really, really long, complicated, sometimes boring process where you have to go through all of the data and then say, like, we're going to formulate a recommendation, but is this really a public health problem? Deb already said it. Hepatitis B, there's no public health problem that they're solving. So that would be a no. Like, what is the risk benefit, right? So they look at that in detail. What is the implementability? Like, what is the effect on equity? What is the cost effectiveness of such a recommendation? So again, if you don't look at all of the domains, what you get is a kind of a mess. And so, what you can see playing out pretty clearly on the ACIP is that there is no sort of reality testing for the recommendation because they don't go through that methodical process. And so even though it's kind of boring, even though it is very processy, it is certainly not bureaucratic. It is scientific. And so, like, when you hear them say, we didn't do grade or we don't have an evidence to recommendations framework, that's a lot of bureaucracy, which is what some of them say. That is not the case. It is designed so that we don't make fast and loose decisions for the health of our country. When it's not used, the decisions are fast and loose. Hepatitis B is not just transmitted sexually. It's not just transmitted during birth. It can be transmitted by caregivers. And one of the more disturbing things that we heard was this sort of bizarre voyage down immigration and sort of the pointing towards subgroups that need to be, potentially profiled to be able to figure out what the right thing is to do for people. And I'm an HIV doctor by training, right? That's what I do. And so that really felt a lot like 1981, talking about like the groups that were affected that then resulted in a myopic view of the epidemic and ultimately pretty damaging sort of impact on stigma. So that's grade and ETR in a nutshell with my 2 cents worth on what happened at the meeting.
That was perfect. I want to have a follow-up, but Dr. Jernigan, go ahead and.
Yeah, I think just to say that when you think about what the secretary said prior to becoming the secretary, there are things that they want to see happen. And so they don't want to go through the scientific process to get to what that appropriate recommendation is. They start with the recommendation and find the science. We've described this as moving from evidence-based decision making to decision-based evidence making, and so that's what's just on stage here throughout. And so it's a part, I think, of a pattern of what they're doing, where they're raising the bar on regulations. They're increasing the amount of risks that they talk about at the ACIP meeting. Some of them are unfounded risks. They're playing down the benefits of the vaccines. And I think that that's really leading to people, it's sowing confusion, especially in parents. And that's just driving down the use of the vaccine. And so that, to me, that's what they want. And that's what's been happening. And it's been a fairly successful activity so far.
Right.
And actually, one thing just to add is, when we were there, thimerosal, which is, an additive in vaccines, our staff had posted a scientific review on it. It was taken down at the direction of the secretary in his office. And the three of us here, had to, kind of be investigated, or at least, talk with attorneys about it. That doesn't really promote scientific publications and among staff, to produce evidence-based reviews if they're not in line with a political or ideologic agenda. So concern is what will be posted at ACIP or what scientific staff will do could be subject to political interference like that.
Right. So I think that's a good segue to our sort of final section before I jump into some questions. So in your Lancet study, sorry, you mentioned that the CDC's current condition is critical but not terminal. It can be rebuilt. And I think, from my perspective, it seems like a big problem, and maybe you can just, if you agree or not, is the trust that people have in public health, in expertise. And so you talk about rebuilding staff, recreating teams. Do you have any thoughts about how to build back trust in public health generally, especially with all of the things that Dr. Jernigan was just mentioning, with this erosion of trust from the agency that's, there's a lot of confusion and misinformation and disinformation that's being generated now. Is there a way forward there that you see? And anyone can chime in if they
I can start. I do think is it over? No, it is not over. There's still very good people that are at CDC. There's still good work that can come out of CDC. In the vaccine space, I'm very concerned about the ability to have good recommendations there. There is a role and a need for the professional societies to really step up. American Academy of Pediatrics, the American Association of Family Physicians, American College of Physicians, IDSA, AMA, all these groups need to coordinate and come up with a way that they can help Americans understand what's right and what's wrong here, and have an authoritative voice that fills in the gap that CDC once had. So there's an offloading of certain activities that probably needs to happen. The evaluation from a scientific and objective standpoint, the Vaccine Integrity Project has been doing a very good job of. The ability to put some of the communications out to the US through some of the alternatives that the New England Journal is doing. Those are things that are helpful. They should be coordinated, but we don't want that to be the end game. We want that to be an interim activity that would allow for CDC to come back. And I do think, while it's difficult, there is the opportunity for CDC to become more efficient, to get better. That's going to take some time, but it also means that we have to we need to think about what we're trying to do in a strategic approach of what we want public health to look like next. And the time to start working on that would be now.
Okay. So I would love to talk with you for much longer, but we're getting towards the end, so I wanted to get to a couple questions. So we have one from Fishy Says, I think, and the YouTube chat. What can other professional or respected organizations do to help in this environment? So I think you might have mentioned this just now with coordinating. What can individuals like us do to help? And so one thing I did want to ask and didn't get to is what sources of information also do you guys look to now? Do you feel like is a good evidence-based if the CDC is not where it should be?
So I can start. So I think that organizations should reach out to their local health departments and see how they can be useful. I think that that's a really important step, because I think that the onus of interpreting data has moved from CDC over to the local health departments, and some of them are really equipped to do it and some of them are not. And so having as much support from professional organizations, I think, will be really important. And that, I think, is the answer to my other question, which is that, the problem is, if you can't trust parts of the CDC website, can you trust all of them? And I feel like that's the answer is that, and I've spoken to jurisdictions about this, no. So they're concerned. And so now the burden is that they have to look at that information and try to interpret it in a way to separate signal from noise. And so I think that the right answer is to keep, stay with your providers, your local health department, your state health department, which I think are going into overtime to try to make sure that they're providing the best analysis of the data that is being put out of CDC and helping you differentiate between signal and noise.
Got it.
And I would say organizations should use their voice. Like, this is not a time to be silent. You become complicit. And it should not be political. It should be focused on health, health and scientific integrity. So organizations, if there's something that they see that is not consistent with scientific integrity, or could hurt people, like the number of vaccine preventable deaths we've had this year, they should call it out.
So we have a question from Hey Mr. Bobcat on YouTube. Do remaining career scientist staff have the capacity to register database disagreement with policies and announcements pushed out by political staff? Would doing so have meaningful impact?
It won't get through.
Yeah. I think that's sort of what I said earlier, which is that data goes up, but no one can speak on it. And so I think that and quite certainly you wouldn't want the people who are in the immediate office of the director speaking on the data, because they don't have the expertise to do so. So in effect, what happens is data goes up and CDC is silent.
Got it.
I think the secretary has stated that, get rid of the center level and we'll put the deputies in. If they don't agree with what we're doing, we just keep going down until we find somebody that does agree. And that's not a great formula for a scientific agency where those people are in those positions because of expertise, not because of management per se. So I think it's very difficult for somebody, if they're confronted with something they don't agree with, to speak out on it, because the chances that they'll get released or put on administrative leave are pretty high.
So one more, I think, then we'll wrap for the day. Jacob Miller, 2718, asks, what would you say to people who say leaving CDC might actually cause long-term harm for short-term wins? For example, vacating a spot for another MAHA member to fill, or you've given up whistleblower ability. What are your thoughts on that, if anybody has any?
Everyone has to do what's right for themselves. We stayed as long as we could, and people left before us. There's still people there. Each person has to just wrestle with what their lines are.
Right. Okay, well, I think let's see. Maybe we'll take one more. So we're still tracking multiple concurrent infectious threats from H5N1 to measles resurgence. How is the current dysfunction of the CDC likely to change the trajectory of these outbreaks over the next 6 to 12 months? That's a question.
Yeah, personally, we're seeing more of those because of the actions that have already been taken, and so I think we'll see more of those as the levels of vaccination for measles will drop. You will start seeing more cases, and you'll start seeing it get into pockets that may have been protected previously. So in that sense, we may see more of them. We may see less information about them, and if they become big, we may see responses to them that are not the traditional approaches the CDC would take.
All right, well, thank you so much. I think we'll leave it there. I really appreciate the time that you've spent today with us, and thank you again. We're really honored to have you. Thank you everyone for tuning in and asking some questions. And so we'll say goodbye for now, and happy holidays.
All right, thanks a lot.
Thank you.
Take care.